The angiogenesis inhibitors can upregulate VEGF, can recruit high concentration of T suppressor cells, other elements that may work immunologically against the tumor. When I say against, I mean reduce the efficacy. So combining immunotherapy with VEGF inhibitors may help nullify those modes of resistance. And this has at least panned out possibly clinically in phase 1, phase 2 trials combining ramucirumab with pembrolizumab. But the door is open to other VEGF inhibitors. Certainly bevacizumab is being looked at this setting. Some of the TKIs also are being looked at. It's certainly not standard as yet. IMpower 150 is really the only frontline regimen I'm aware of for frontline trial that looks specifically at combination VEGF inhibition, in this case bevacizumab with PAC-carbo, comparing that regimen to the same triplet with atezolizumab. And in fact, that trial was strikingly positive. We see a survival advantage on the range of 4.5 to 5 months. That advantage is seen in individuals who have oncogenic drivers, molecular aberrations such as EGFR and ALK. There, the control arm had a median survival of 17 months, and the investigational arm, it's not even been reached as yet. We also see in the opposite end of the spectrum, in patients with visceral dominant disease such as liver metastases. And in fact, in those two groups, the hazard ratios are better than the larger, less selected population. So the role of combination angiogenesis inhibition and immunotherapy is real. It's in the here and now. And in fact, if we go back to that trial and look at the curves, specifically at the PFS curves, they seem to separate more over time after the chemotherapy is completed, strongly suggesting that, in fact, there may be some special synergy between bevacizumab and atezolizumab. There have been a number of trials in individuals with molecular aberrations, particularly EGFR mutations, comparing erlotinib alone to erlotinib in combination with bevacizumab. And those trials have shown significant improvements in progression-free survival, a 5, 6, 7-month advantage for the combo. Unfortunately, as presented at ASCO 2018, that is not translated, or at least not yet translated, into an overall survival benefit, and which is a shame, because I truly think that beyond survival, we need to consider quality of life. We need to consider the duration of response. These individuals, though, if they're on a TKI, it's a pill. They don't need to come into the hospital or into the clinic that often. Once you put them on an angiogenesis inhibitor such as ramucirumab or bevacizumab, they're tied to the clinic every 3 weeks. So that's the major disadvantage. On the other hand, if I were a patient and had an EGFR mutation, I might opt for the combination simply to extend my progression-free interval. This will be explored further. There are similar studies looking at osimertinib now with angiogenesis inhibition, and studies looking at ALK inhibitors with angiogenesis inhibition, but those haven't been reported out as yet.